As I do the opening. Good afternoon. Welcome to Preventive Medicine Grand Rounds for December 1st, 2021, the first day of December. I'm Antonio Neri from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship and the Health Resources and Services Administration Bureau of Health Workforce. The PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed CDC's Epidemic Intelligence Service program or have equivalent public health experience. The Preventive Medicine Grand Rounds, the Preventive Medicine Residency and Fellowship is pleased to announce the opening in January 1st of 2022 of the Population Health Training in Place program application for the 2022 class that would start in July of 2022. This year, physicians seeking board certification in general preventive medicine and public health will be eligible to be considered residents of the CDC Preventive Medicine Residency and Fellowship through the PHTIP program. You can find more about these two programs on our website, cdc.gov/prevmed. You can see we use Zoom for audio and the presentation and the question box to pose questions. Note that you can pose questions via the text box at the bottom at any point during the lecture, and those speakers will work on answering them at their discretion. Note your name may appear associated with the question you pose. If you do not want your name to be associated with the question you posed, then check the box Submit anonymously. Continuing education credits are available for the live course for up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this Grand Rounds is all capital letters CDC PMRF. Again, all capitals CDC PMRF. If you have questions, please contact myself or email the program at prevmed@cdc.gov. Please remember that the views presented by the speakers are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Before we start our presentation, I want to always take our usual moment of silence over this last year and a half or further of the pandemic, just to recognize the friends, colleagues who have suffered morbidity and mortality from COVID, and those who have persevered to work so hard to provide care and public health for people so they don't get affected by COVID or treat those that have been. Okay, so today's Grand Rounds will focus on big data analytics, and I'm super excited. We have 3 fellows from different components of the CDC fellowships within our division, and I think we were talking about it a little bit earlier, but big data is critical. It's increasingly important in this day and age, and I can tell you at the agency, I think we have a very difficult time trying to understand what big data, how to analyze it, how to manage it, and how to analyze it. Not what it is, but how to analyze it and manage it. And my assumption is if we're struggling at CDC to do this, I can guarantee the state and local health departments that we are engaged to support are doing it as well. So I'm super excited to present our speakers today, and I'll let them take it from here. Thank you so much for all for coming. The floor is yours.
Hello, everyone. Thank you for joining us. We are delighted to be here presenting at the Grand Rounds. My name is Juliet Adeola. Myself and my colleagues, Raul and Allycia, will be presenting the big data analytics and applications in public health. The 3 of us are fellows belonging to the 3 different fellowship programs, but we are all located in the Population Health Workforce branch in the Division of Scientific Education and Professional Development within the Center for Surveillance, Epidemiology, and Laboratory Services. To share a little bit about our team, we are under the supervision of Dr. Mark Messonnier, lead economics in the Population Health Workforce branch within the Division of Scientific Education and Professional Development in CSELS. At the beginning of this year, Mark noted our overlapping interests and brought us together to form a cross-fellowship collaboration within the branch. I'll let the others introduce themselves. But again, my name is Juliet Adeola. I am a second-year fellow at the Public Health Informatics Fellowship Program. Over to you, Allycia.
Thank you, Juliet. Hi, my name is Allycia Kleine. Thank you for having us today. I am a second-year ASPPH Fellow, which falls under the Academic Partnerships to Improve Health program.
Raul?
Hi, my name is Raul Segura. Thank you very much for the invitation to the Grand Rounds presentation series. I'm a Prevention Effectiveness Fellow, and I'm also an economist by training.
Thank you very much. Thank you for the disclaimer. I would like to also say that we echo that the findings and conclusions in this report are those of the authors and do not necessarily represent the official position of the CDC. Our outline for today, during the presentation, we will discuss the transition from small data to big data. We would look at what is big data analytics and tools, big data use cases and domains. We will also take some time to talk about the big data analytics and applications in public health program. And also we'll talk about our Bdap strategies and resources. Next slide. So let's start by looking at where data is coming from. Big data comes from a variety of sources, machines, people, and organizations. Machine-generated data refer to data generated real-time using sensors in industries, machineries, airplanes, or vehicles. Today, there are activity logs that track user behaviors online, environmental sensors, or personal health trackers. We can imagine a world of smart devices at home, in our cars, in the offices, city, remote rural areas, in the sky, even in the ocean. All of these devices are connected together and generating data. Big data also can come from human sources such as Facebook. As you can see, a lot of people are making different posts on Facebook. Also, you see a lot of videos uploaded to Instagram, photos on Instagram, videos on YouTube. An enormous amount of information gets generated by people, even through blogging and commenting, internet searches, text messages, email, and through personal documents. This is what the story looks like today. Before now, traditional data was just mainly data from numbers, text, and then we had images, audio, and today we have high resolution data that actually go in large volumes. We'll talk a little bit about that. Finally, data also comes from organizations. Organizations generate data, which include transactional data from structured databases or warehouses. Each organization has distinct operation practices and business models, which result in a variety of data generated. For example, the type and source of data that a bank generates is different from what a healthcare provider generates. Organizational big data comes from commercial transactions, credit cards, government institutions, e-commerce, banking or stock records, medical records, sensors or transactions, clicks, and so on. Having described the sources of big data, we will now move to talk about what exactly is big data. We will now define big data. What is big data? Big data refers to any collection of data so large and complex that it exceeds the processing capability of conventional data management systems and techniques. A set of characteristics or qualities define big data. Big data is commonly characterized using a number of V's. Today's discussion, we will describe the 5 V's of big data. 4 of these V's are categorized as technical characteristics, while one of them is seen as a business characteristic. I will take some time to talk about the 4 technical characteristics that we use to describe big data. The first is volume. Volume refers to the size of the vast amounts of data that is generated every second, every minute, hour, and day in our digitized world. But how much data are we talking about? We all know that data is measured in bytes. We know that 1 byte is equal to 8 bits, but when we move up the ladder, 1,000 bytes is equal to 1 kilobyte, and 1,000 kilobytes, 1 megabyte. 1,000 megabytes gives us 1 gigabyte. And today we have 1,000 terabytes, 1,000 gigabytes giving us 1 terabyte. And we are also gone up to exabytes and zettabytes. And these are all in thousands of bytes. A couple of encyclopedia may be about 100 megabytes, for example, just to show you what we mean by these measurements. A DVD can actually accommodate as much as 5 gigabytes of data, while 300 hours of good quality video can be stored in about 1 terabyte. It therefore means that large data sets are usually more than 1 terabyte. The second characteristics of big data we would like to discuss is velocity. Velocity refers to the speed at which data is being generated and at the pace at which data moves from one point to the next. If this data is happening real time, or if this data is being collected and stored for batch processing, which actually takes a very slow speed. The third would be variety. Variety refers to the ever-increasing different forms that data can come, such as text, images, voice, and geospatial data. Data can be structured, data can be semi-structured or unstructured, coming from different sources. We'd like to also talk about veracity, which refers to the quality of the data. And quality of the data can vary. This characteristics covers the biases, the noise, the abnormality in data. It refers to the often unmeasurable uncertainties, truthfulness, completeness, and trustworthiness of data. We will not complete the V's of big data without talking about the business characteristics. The essence of collecting and processing data is to uncover patterns and trends and use the results to make more informed and data-driven decisions. Hence, we'll talk about value. Value refers to how big data benefits an organization. Processing big data usually brings about value from insights gained from the analysis. Analysis of business performance, such as costs, delivery time, web tracking tools, and social media analysis are some of the value organizations can get from big data. We can see that these 5 V's described define big data, an enormous collection of data, which is often so large, talking about volume, complex, talking about variety, fast speed, talking about velocity, and of course, quality, looking at veracity, and then the insights or value we gain from all of this analysis. We'll take a moment to talk about the big data use cases and domains. The applications and business use cases for big data are endless. Healthcare, travel, finance, education, telecom, all are some examples where big data analytics is applied. Every part of business and society today are changing in front of our eyes due to the fact that we now have so much data and also ability to analyze them. So we'll take our next slide, we'll be talking about big data analytics. What is big data analytics? Big data analytics refers to the process of analyzing large data sets to identify useful insights, you can say to identify value. Useful insights, correlations, and patterns to improve decision-making. Big data analytics in general sheds light. Once you have such insights, then you will be able to perform data-driven actions and also take data-driven decisions. Harnessing big data analytics can deliver big value to businesses' scientific world, adding context to the data that tells a more complete story. Our next slide will take some time to talk about types of big data analytics. There are 3 types of big data analytics. The first one is the descriptive big data analytics. Descriptive analysis is always at the bottom of the big data value chain, but they can be very valuable also because they uncover patterns that offer insights. Big data is based on live data, tells us what is happening in real time, tells us what has happened in the past because data has been collected in the past and is still being collected. Descriptive analytics focuses on what happened in the past and what is happening now based on incoming data. Mining this data will typically produce real-time dashboards, email reports that add value to the organization. An example of descriptive analytics would be harnessing credit risk using past financial performance to predict a customer's likely financial performance. Would like to move over to the second type of big data analytics. The second type is predictive analytics. Predictive analytics asks the question, what will happen in the future? It tells us what's likely to happen based on historical data and assumes a static business plan or model. Would like to also say that this kind of analytics actually helps us with what should we do? What is the best solution? This type of analysis reveals actions that we can take, recommendations, rules, and probably next steps. One of the benefits of this kind of analysis is in healthcare industry. It's possible to better manage patient population by using this kind of analytics. We can actually predict patient adherence to treatments. We can forecast what will happen in terms of health outcomes using available data. The last big data analytics that I would like to discuss today is the prescriptive big data analytics. The prescriptive big data analytics actually talks about what should we do now that we have all of these data sets. What can we do? So this type of data, or this type of analysis actually tells us what we can do in a situation whereby we have analyzed the data that we have collected. It defines future actions based on current data analytics. It helps us also to use advanced algorithms to test potential outcomes of each decisions that can be taken. At this point, I would like to move over to talk about big data analytic tools. Looking at the big data analytics and the different types of analytics that we can conduct, it's become important to look at what tools are available to support big data analytics. To support big data analytics, innovation technologies are needed. Parallel distributed computing architecture, scalable machine learning algorithms, and real-time querying are very key to analyzing big data. As shown on the slide, we can see that big data has a layered and tiered architecture like most software and the cloud. There are diverse tool suites that you can see on that framework that can be used. These tools can be integrated. These tools can work together. These tools can be managed and administered for big data analytics. Let's take a look at each of these tools and what they do. First is storage. With increasing volume of data today, tools such as Hadoop distributed file system, cloud storage like AWS, Amazon Web Services are necessary to support storage of this large amount of data or volume of data that is generated. When we talk about speed, Today, we talked about volume as one of the characteristics of data, big data, and we also talked about velocity, talking about the speed with which data is being generated. Today, we will require parallel processing so that we can have data processed in real time. To be able to do that, we have Hadoop and Spark as tools that can handle processing of large-scale data in the most cost-effective manner. Talking about database management and data analysis, we have no SQL alternatives. Some of us know what we mean by SQL as relational databases, but big data supports structured, semi-structured, and unstructured database. So no SQL alternatives such as Apache CouchDB, Apache Cassandra, and Apache MongoDB are very useful tools that can support database analysis in big data analytics. Also, we have data analytics tools that can help with algorithms, machine learning algorithms, such as Python and R. The essence of big data analytics is to be able to visualize or to show our results, and then, of course, the value added in a readable format in a way that it will be easy for decision-making, hence the visualization layer. Big data analytics supports Tableau. Power BI can also be integrated and others to support visualization. Because the different products are targeted at different communities and needs, organizations planning to use big data analytics will need to manage the diversity of tools by working closely with vendors such as Cloudera, Hortonworks, and other cloud vendors to support with big data analytics tools. At this point, I would like to thank you for your attention. And as I turn it over to my colleague, Raul, who will be taking us through the next session. Raul, please, over to you.
Thank you, Juliet. I'm going to start talking about big data applications in public health. Traditionally, predictive modeling in population health has relied on parametric statistical regression models. But more recently, there has been an increasing interest in the use of machine learning methods to make predictions in this field. However, the benefits of these models can only be fully leveraged when applied to big data sources, which are based on a large number of observations or features, or both. Population health prediction models can be used to identify high-risk groups, directing the implementation of preventive interventions, and can also anticipate future disease burden, as well as help policymakers assess the impact of public health actions. A wide range of population health outcomes have been the focus of machine learning prediction models. These outcomes include non-communicable and communicable diseases, as well as those which are classified as non-disease. We have conducted a content curation by reviewing some relevant articles from the literature. Those articles are organized by the type of outcomes and listed in a document that has been created and is accessible upon request. Next slide, please. Artificial intelligence describes a machine's ability to use big data when learning to act like a human. A set of applications of artificial intelligence on COVID-19 has been proposed. First, artificial intelligence allows the analysis of irregular symptoms and other red flags, and with the help of computed tomography and magnetic resonance imaging scan, is also useful in the diagnosis of infected cases. Second, artificial intelligence can build intelligent platforms for automatic monitoring and prediction of the spread of the virus. Third, artificial intelligence can help identify the clusters and hotspots and successfully do the contact tracing of the individuals. Fourth, artificial intelligence can predict the future course of the disease and the possibility of reappearance. Fifth, artificial intelligence is used for drug and vaccine development in speeding up the testing process. Sixth, the use of artificial intelligence can make certain time-consuming repetitive processes faster and more efficient. This allows healthcare workers to spend more time on tasks that focus on the clinical context of their patients and attending their needs. And finally, artificial intelligence can provide updated information that is useful in the prevention of the disease propagation using real-time data analysis, since it allows to identify traits, causes, and reasons for the spread of the infection. Next slide, please. To motivate the topic of big data analytics, I am going to discuss two scientific articles that apply machine learning techniques on the health field. The first article addresses the prediction of coronary heart disease using an integrated approach. Next slide, please. An improved method for detecting coronary heart disease, CHD, could have substantial clinical impact. CHD risk factors are a conglomeration of genetic and environmental factors. The goal of this study was to demonstrate the viability of an integrated approach that relies on genetic, epigenetic, and phenotype data in predicting CHD status as an alternative to models that are based on conventional risk factors. In so doing, authors first developed an integrated CHD prediction model, then developed a CHD prediction model consisting of conventional risk factors, and lastly, compared the CHD prediction performance of these two models. While the models in the study are initially being used to classify individuals based on their current CHD status, they will also set the stage for the eventual development of genetic epigenetic markers for predicting CHD prior to its occurrence. In other words, for forecasting purposes. The clinical, genetic, and epigenetic data included in the study is from the upstream cohort of the Framingham Heart Study, who first attended the 8th examination cycle, which was conducted between 2005 and 2008. Second, consented to genetics research. And third, have peripheral blood genome-wide DNA methylation data. The authors provide a table with the p-values of the 30 significant methylation sites associated with symptomatic CHD after bump-Veronic correction for multiple comparisons. The single nucleotide polymorphisms, SMP, are the most common type of genetic variation among people. The total number of genetic SMP and epigenetic DNA methylation probes that remained after quality control were over 403,000 and 472,000 respectively. Finally, phenotypes include age, gender, systolic blood pressure, high density lipoprotein cholesterol level, total cholesterol level, hemoglobin A1C level, self-reported smoking status, the use of statins, CHD status, and the date when CHD was established. Next slide, please. As previously mentioned, the goal of this study was to develop an integrated genetic epigenetic classifier for symptomatic CHD. To achieve this, training and testing datasets were prepared to develop the classifier and subsequently test its predictive capability. The classifier was trained on 1,545 individuals and consisted of 4 DNA methylation sites, 2 SNPs, age, and gender. The methylation sites and SNPs were selected during the training phase. The variables that were retained from prediction were based on first, the average accuracy and area under the curve of the 8 classifiers, and second, the information gain criteria of each variable. The final trained model was then tested on 142 individuals. The authors used a stratified 10-fold cross-validation approach by building random forest classification models on 8 training datasets using the scikit-learn machine learning library in Python. Next slide, please. Table 3 displays the performance metrics of the 8 integrated genetic epigenetic random forest models, which contain 4 DNA methylation sites, 2 SNPs, age, and gender. Table 6 shows the performance metrics of the 8 traditional random forest models, which include only conventional CHD risk factors as predictors. Accuracy is a proportion of correct predictions for the test data. In order to evaluate this metric, we must divide the number of correct predictions by the total number of predictions, which also include those which were wrongly made. Accuracy ranges from 70 to 80% in the integrated models and from 70 to 76% in the conventional models. Sensitivity, also called true positive rate or recall, is a measure of how well a test can identify true positives and is defined as a fraction of true positives over all the positives, which also include those that are false negatives. Sensitivity ranges from 70 to 82% in the integrated models and from 67 to 74% in the conventional models. Specificity, also called true negative rate or selectivity, is a measure of how well a test can identify true negatives and is defined as the fraction of true negatives over all the negatives, which also include those that are false positives. Specificity ranges from 70 to 79% in the integrated models and from 72 to 79% in the conventional models. The receiver operator characteristics ROC curve is an evaluation metric for binary classification problems. It is a probability curve that plots the sensitivity or the true positive rate against 1 minus the specificity or the false positive rate at various threshold values, and essentially separates the signal from the noise. The area under the curve is the measure of the ability of a classifier to distinguish between classes and is used as a summary of the ROC curve. The higher the AUC, the better the performance of a model at distinguishing between the positive and the negative classes. When the AUC is equal to 1, the classifier is able to perfectly distinguish between all the positive and negative class points correctly. When the AUC is equal to 0, the classifier would be predicting all positives as negatives and all negatives as positives. When the AUC is between 0.5 and 1, there is a high chance that the classifier will be able to distinguish the positive class values from the negative class values. This is so because the classifier is able to detect a higher number of true positives and true negatives than the number of false positives and false negatives. When the AUC is exactly equal to 0.5, the classifier is not able to distinguish between positive and negative class points. This is because the classifier is predicting the classes either randomly or constantly for all the data points. The area under the curve of the ROC ranges from 0.77 to 0.87 in the integrated models and from 0.72 to 0.79 in the conventional model. Overall, the integrated genetic epigenetic model is partially superior to the conventional model in accuracy, sensitivity, and the ability to distinguish binary classification. These results demonstrate the capability of an integrated approach to effectively model symptomatic CHD status. Next slide, please. The second article discusses the use of administrative data to predict short-term mortality. The authors of this article come from different educational backgrounds. One of them is a professor of economics at Harvard University. Two of them are computer scientists from MIT who focus on creating and applying machine learning techniques to understand and improve health. And the fourth one is a physician and a researcher who works at Berkeley University. Next slide, please. Risk prediction is a central topic both to clinical medicine and public health. Physicians and patients frequently face important decisions regarding medical care at the end of life. These decisions range from aggressive curative treatments to comfort-oriented palliative care, and they heavily depend on a patient's expected survival or prognosis. For example, high-risk interventions such as surgery or chemotherapy may be reasonable options for patients with longer expected survival, but are less well-suited to patients with poor prognosis. The adoption of the Affordable Care Act increased the interest in strategies to target patients with poor prognosis through interventions that improve their quality of care at the end of life and also reduce costs at the same time. Despite its importance, there are only a few examples of mortality prediction models being used in real-life clinical or policy setting. This is mainly for two reasons. First, approaches to identification of high-risk patients in the clinical literature rely on logistic regression to predict mortality using small datasets, both in terms of number of observations and number of features. This approach not only produces biased coefficients, but also underestimates predicted probability of rare outcomes, such as death. The second reason is that even though machine learning contains many tools for predicting clinical outcomes, they heavily rely on variables or features that are derived from genomic data, vital signs, laboratory tests, etc., which are not typically available in databases used by clinicians and policymakers. Therefore, machine learning methods using these data sources do not have a clear path to implementation in a real healthcare environment. The authors in this article explore the performance of several machine learning techniques for the prediction of short-term survival using an administrative claims database of the kind that is available to most healthcare payers and providers. Next slide, please. In order to develop their model, the authors relied on Medicare claims data, which capture patient demographics, health utilization, and recorded diagnosis from the time of enrollment until these patients die. They used a nationally representative 5% sample of all the fee-for-service beneficiaries in 2010 and retained those who were over 65 years old. They included those beneficiaries not enrolled in the Medicare Hospice Benefit Program, since these beneficiaries already have a known terminal disease. At the start of an arbitrary date, in this case, July 1st of 2010, to mimic a real-life situation in which predictions are needed at a discretionary point in time. 4 disease cohorts were selected to explore how predictions vary across a range of underlying medical pathologies and mortality rates. However, they only presented the results from the tumor group, since relative performance of classifiers was very similar across 4 disease cohorts. The randomly chosen sample with 20,000 beneficiaries in each disease was equally divided into training and validation datasets. The outcome of interest target is whether or not the death of a patient has occurred within the 6 months after the arbitrary date. 6-month survival is a major eligibility criterion for the hospice benefit, making it a useful interval for both physicians and patients to start considering the goals of end-of-life care. Next slide, please. The features included in the traditional models contain age, sex, and a set of 20 binary variables corresponding to individual diseases or conditions. These independent variables have been previously identified as good predictors of mortality using administrative data. The augmented models contain the features from the traditional models, as well as income deciles, functional status, which captures ability to live and function independently, durable medical equipment, and healthcare utilization. In order to capture disease severity, the authors replaced each of the 20 comorbidity indicators from the traditional model with 2 count variables representing the total number of encounters, which can be clinic or emergency room visits, and inpatient or skilled nursing facility stays, involving that comorbidity, in 2 time periods, 1 to 3 months and 3 to 12 months prior to July 1st. These features capture not only the presence or absence of the disease, but its severity measured by the number of encounters, and the evolution over time measured by encounter differences from a recent period with respect to a baseline period. Next slide, please. 6 classifiers were implemented: naive Bayes, support vector machines, k-nearest neighbors, artificial neural networks, random forests, and logistic regression. The area under the receiver operating curve was chosen as the performance measure for all classifiers. The development dataset was split into 2 randomly mutually exclusive samples of equal size: the training sample and the tuning sample, which was used to tune the parameters. Next slide, please. The first table shows the area under the curve using augmented and traditional variables. Based on the validation dataset, I'm focusing only on the tumor group. We can see that the best performing model was the random forest using the augmented variables. Lasso was the best performing classifier using traditional variables. Also, all classifiers performed better when trained using the augmented variables. The next table shows the validation area under the curve by disease cohort using the augmented variables and based on the random forest algorithm. The tumor cohort had the highest performance measure, regardless of the split choice. Next slide, please. The authors developed an augmented set of variables that capture different aspects of patients' health condition using nationally representative administrative claims of beneficiaries. This study shows that machine learning classifiers outperform currently widely used methods for risk prediction, but only when used in combination with an improved feature set that incorporates insights from clinical medicine. This was likely the result of two main factors. First, these variables quantify disease severity by using counts of encounters rather than simply presence or absence of the medical encounter or disease. And second, they capture disease progression over time by splitting the variables into two discrete periods. The study has applications to supporting patient and provider decision-making regarding the end-of-life care. On an aggregate population level, it could also serve to identify patients at a high risk of poor outcomes, which is an input that can be used to manage and improve health of populations by predicting short-term mortality of several comorbidities. I'm going to turn it over to Allycia, who will be talking about the Bdap program. Thank you.
Thank you, Raul. So now that we've discussed what big data is and how big data can be applied to public health, we'll use the next part of this presentation to discuss our ideas for the Bdap program, which is currently in the development stage. As Juliet and Raul have demonstrated, the rationale for our program stems from the rapid evolution of big data analytics, or BDA, and its crucial application to public health research. We believe that public health scientists need to harness the potentials and opportunities that BDA can offer to use their benefits to predict and prevent diseases and improve health. However, gaps between existing BDA tools and some of their potential users still exist. Most of the identified gaps revolve around the knowledge and applications of BDA techniques to solve public health problems. It is our hope that the Bdap program will help advance the use of BDA techniques in the public health sector using data from sources within and outside of CDC. The main goal of the Bdap program consists of reinforcing the capacity and technical skills of public health scientists to leverage big data analytics to tackle public health challenges. In order to achieve this goal, 3 objectives have been proposed. Firstly, to expand the existing knowledge and the applications in the public health field that can be derived through the development of a program curriculum and its corresponding content delivery. This will ultimately involve putting together collaborative efforts. Secondly, to foster an interest for the Bdap program by using traditional learning methods, mainly based on the achievement of competencies, as well as more modern approaches which rely on project-based learning. Thirdly, we will eventually plan to evaluate the program outcomes and its impact using performance measurement and the attainment of demonstrated mastery. Here we have the outlined strategies and activities of the Bdap program. The top row of icons constitutes our identified strategies, and the bottom row is our activities. We've already touched on some of the activities in the bottom row, and we'll mention a few more shortly, so I'm going to turn our attention to the top row. Firstly, we have developed and are currently distributing a baseline knowledge survey. This will be used to measure potential learners' familiarity with and proficiency in big data competencies. The results, which will allow us to gauge existing knowledge and skill sets, will help us to develop a relevant and effective training curriculum. Regarding curriculum development, ideally the Bdap curriculum will cover 2 domains of knowledge: public health science and big data analytics. We are currently working on the implementation of an introductory course on public health science in the big data era. The goal of this course is to motivate participants to begin thinking about how they can use big data to address public health problems by providing them with an introduction of the fundamental concepts and tools, as well as by discussing some recent applications in the public health field. The target population for both the baseline survey and the curriculum development is currently population health workforce branch fellowships. In the future, we would like to reach a wider audience, but for now, we are starting on a smaller scale in order to pilot the program and assure its effectiveness. Also to note, both the baseline survey and curriculum development have been approved on the e-clearing system. So moving on to cross-fellowship collaboration. As we mentioned in our introduction, this project idea was originated through discussion among fellows who belong to 3 different fellowship programs. It is our intention that this project initiative can motivate similar inter-program collaboration in a multidisciplinary environment. And then finally, partnerships with CDC groups. The Bdap team plans to collaborate with partners and existing communities of practice in the development and implementation of relevant course curriculum, individual course objectives, and content delivery options. There will be many benefits of the Bdap program. If the program is developed as planned, Bdap will offer a flexible, structured, self-paced training schedule for learners. The curriculum will span across big data technologies, machine learning, and applications in public health. As previously mentioned, advancing public health scientists' knowledge and skills in these areas is critical as the application of big data analytics continues to evolve and help solve public health problems. We envision that the Bdap course curriculum will be accessible to learners of all academic backgrounds and at all skill levels through curriculum development for both learners with and without experience in big data analytics. The results of our baseline survey will allow us to recommend the relevant curriculum to learners. After completing the courses, learners will ideally be guided to apply what they have learned to solve real-world examples of public health problems. By using a project-based learning approach, we will ensure that Bdap learners gain hands-on practical experience. Promoting multidisciplinary cross-fellowship collaboration, again, is a key component of Bdap. As fellows from the various fellowships participate in the program, we plan to provide opportunities for the learners to discuss course content, provide feedback to one another, and to collaborate on projects. Lastly, we envision technical assistance and supervision being provided for participants throughout the program through the development of an online resource center. As a final note, we would like to share this quote by John Hull from his book, Machine Learning in Business, An Introduction to the World of Data Science. It reads, "A human plus a trained machine is likely to be more effective than a human or a machine on its own for some time to come. However, we should not underestimate future advances in machine learning. Eventually, machines will be smarter than human beings in almost every respect. A continuing challenge for the human race is likely to be how to partner with machines in a way that benefits rather than destroys society." We see this quote as really emphasizing the importance of us as public health scientists, strengthening our capacity and use of big data and big data analytics techniques to address public health problems. We'd like to take a moment to quickly acknowledge those who have been essential to the progress thus far of the Bdap program. The support and guidance that we have received from these individuals and groups has been greatly appreciated. So again, thank you for your time and for your attention. Please don't hesitate to reach out if you have any direct questions or comments, but now we will open it up for questions.
Thank you all for doing that. I very much appreciate it. There's one question in the question and answer box, and I have a couple of my own, but I'll let you answer that one. That seems pretty straightforward. Can you all see that?
Yes. The first question, will these slides be available somewhere?
Oh, we'll answer those top 2 ones, but who the target audience was for the survey and the curriculum?
Okay, thank you very much. So our target audience are fellows, CDC fellows, excluding the ORISE fellows for now, for our introductory course.
And then there's another question that came in that asks sort of about future fellowships with public health professionals looking to gain experience in big data analytics. And I'd actually pose that in a bigger question. Can you talk a little bit about other opportunities to train in this area? How you can get more training in this area?
Okay, I'll turn that over to Raul to respond, then I can chime in.
Yeah, so basically we have identified several fellowships that could be potential receiver of it. I mean, might be interested in this type of training, but we are open to any other students or potential fellows that would like to join. Also, not only fellows, but anybody interested in this topic. We believe that is very important and very relevant in today's world. So we basically, like I said, we are open to any kind of audience that is interested in this training.
I'd like to also add there that, thank you, Raul, for that. So we hope that our courses would be available on public spaces, especially within the CDC platforms that people can easily go and take those courses. And as much as possible, as we kickstart, we would also expand our reach. Thank you.
I think, and correct me if I'm wrong, most of the opportunities we're talking about are internal to CDC at this moment, right? Is that correct, Raul and Juliet?
Yes,
yes,
exactly.
At this moment, but we also have a plan, a long-term plan to make our courses available for global audience on Coursera, Aureli, or on any other learning platform that people can actually reach.
And then maybe I'll take that one question a little bit further. If you, as you develop this understanding of big data analytics and the workforce capacity, can you talk a little bit about how non-CDC entities, particularly public and private and academic partners, and particularly state and local health departments, can prepare their workforce to both collect and analyze big data analytics?
Do you want to start? But I can also start. I think one preparation that I would say for now is to also increase capacity, which we are trying to bridge capacity gap, knowledge gap, using these trainings. Also increase training on big data ethics. Also, it's one other place that I see that organizations can start to prepare themselves, talking about data ownership, governance, and access. Those are very important aspects that people need to prepare themselves also with all of this data that we have access to.
Raul or Allycia, what do you think?
Yes, I mean, data access is a critical part of big data analytics, and we acknowledge that part. And so we have at CDC, we have the CDC Data Hub that contains and provides very important data. I mean, the quality data that we envision for this type of projects. But I think that what Juliet has mentioned before, that ethics is an important aspect of the usage of data. And this is something that has been in the community. I mean, being everywhere else is talking about the limitations of between having the right to use data, and also the limitations to use that data so that it doesn't compromise our privacy, for example. So these are things that we are aware of, and we also try to take into consideration as well.
One of the questions is about can you talk a little bit about the common misconceptions about big data and machine learning that you've encountered when you developed the program, or even in your own experience as analysts?
So one of the misconceptions is that big data is large data. People think that you need so much data, so much volume of data before you can call it big data. But from the discussions today, we can see that that is not always the same, the truth. You're looking at the 5 V's of big data. Now we know that it's not only how large, but how complex, and how fast, and quality of data, and then of course value added. So we have better understanding, and then sometimes also people misconstrue and think that big data talk is relational databases, which is like traditional, what we know about, like tables and rows, like Excel sheets and all of that. Now we know that big data, it supports structured and unstructured, semi-structured, all forms of data can be analyzed using big data tools.
Allycia, what are your thoughts on that?
My apologies, I'm responding to the Q&A typing.
Oh, yeah.
Yeah, I don't have a whole lot to add to what Juliet said. They've been mainly doing some of the research, and I'm doing the back end of the presentation. So Raul, did you by chance have anything to add to that?
No, actually, I was reading another question here about the applications of the Bdap and BDA to COVID-19, and I was kind of preparing for that question, but I don't have anything else to add at this point.
Oh, go ahead with that.
So, well, one of the slides that we presented here, we discussed actually talks about the applications of artificial intelligence in COVID-19. And part of our work has been to conduct content curation by reviewing relevant articles, and included that into a document that I think I mentioned during my presentation that would be accessible upon request. So in that particular slide, we mentioned 7 applications of artificial intelligence for COVID-19. And one of them, for example, would be in terms of, for example, drug and vaccine development can be used, artificial intelligence can be used for drug and vaccine development in speeding up the testing process. This is something that is probably now in the media, or has been recently in the media, as new COVID-19 how do you say this Delta variant and the Omicron variants appear. So this is something that I think artificial intelligence can really have a big impact on this particular aspect of vaccine development. In that particular slide that we compiled the information from articles, we selected 7 of them, but probably there are more that we might not be aware of. But this is just to show that there are a large number of applications of artificial intelligence and the tools of machine learning on COVID-19.
Juliet, did you want to add to that, or Allycia? So you feel good about that too, that's fine. The other question is about 2 questions that sort of stem off of one that someone submitted. One is representativity, so big data and what it represents. I wonder if you could talk a little bit about that. For the last 18 months or so, I've been helping out with the telehealth operations at the agency. One of the things we run into in big data sets is how representative the data is. And I think particularly in what are termed now population health companies that abstract data from individual siloed electronic health records and aggregate it, but also de-identify it. It's been very difficult to look at how representative they are of different populations. And I was wondering if you could talk a little bit about that, and I have a follow-on question to that. What's one of those?
I strongly believe that the more data you have, the better. And data coming from different streams and sections if combined, can give us better insights. So even with the machine learning algorithms, you always would need more data. You need enough data to have to do your training. You need enough data to test, and before you can. So the more data that you have, the better. And especially when you also stream in data from different sources, so that your insights will be really well-rounded. So I would say go for more data. Enlarge the cost of your data search, and as much as possible. For instance, we have the CDC data lake, and we can actually go retrospectively, to look at patterns and insights, and then we can work our way forward, to look at what we can implement. So I would say more data, give you more representativeness. More data, I mean, is, diversity in the data, expanding on the sources of data to get better insights.
And one of the approaches I had heard, and Raul, I'd be interested in hear your thoughts as well, is if you run the same analysis in a couple of large data sets and you come up with the same finding, then you can have more security in thinking that represents a true finding. But Raul, what do you think?
Yeah, no, there's a lot of, I mean, in our opinion, I think that one of the main challenges of big data is, for example, in my field, economic theory, there's no theory behind. So it's just they're putting a large number of variables, and then by any performance metrics that are selected, they have to select those variables that do the best job at predicting in this case. So that's a big challenge. That's the reason why you might have several models that provide different results. And that's why you have these common performance metrics that are going to be the ones that tell you which one should be selected for the purposes that you are interested in. So that's the thing. There's no theory behind usually, and that's one of the criticisms that economists or other scholars or scientists usually make towards big data, and that's why that's the reason some of them are very reluctant to using this kind of technologies, because like I said, there's no theory behind that supports. But at the same time, this is something that we have to acknowledge, that as the collection of data, I think that in the last 2 years, the number of data that has been generated is 90% of the total data in the history. So this is something that we need to acknowledge and take into consideration. And unfortunately, traditionally, statistical methods cannot provide a good answer to when you have such amount of data, and especially a large amount of features or combinations of features. So I think that big data analytics nowadays has a lot of things to say, but also in the future, of course, it will be something to take into consideration, even for economists, I would say.
And to take that a little bit further, I wonder if you could talk a little bit about equity and big data and analytics, and either addressing inequities in either workforce capacity or health, or exacerbating them.
Juliet.
Okay, so, sure.
Juliet.
Yeah, I did see that question, and I was still try to make reference to big data ethics. Very important, that we all get, as we plan to use data, collect all this data, it's important that we have informed consent and that people know why the data is being collected and for what. There's need for use agreements, and there's need for policies that would protect the people and also their confidentiality, as to their data being used, because now data looks like publicly available, but there should also be policies to protect the individuals, who are also providing this data. I mean, something, beyond what we are doing currently at the health facilities where care is provided. I know that informed consents are completed by patients, especially when they are getting into research, kind of analysis. So that also needs to be strengthened for big data analytics. Would you want to add anything to that?
Well, in terms of inequities, I think we had, everybody here has had probably the chance to read or learn about cases in which, because one of the reasons that one of the applications of big data is the classifying people. So there have been cases in which the classification that are made using these techniques, given that the data that they've been using contains biases, has exacerbated already existing inequities or inequalities. So this is something that, of course, people that are very much into this field are looking into and taking that into consideration, so that to make sure that the data that they're using doesn't contain any biases or minimize the biases, so that these errors cannot be replicated or even exacerbated.
Yeah, thank you. There's a question about government or GIS use cases, and talking a little bit about where, and that's, so one of the questions is whether we plan to do more with big data. And of course, in the Preventive Medicine Residency Grand Rounds, we do plan to do more with it. But at the same time, are you aware of anything related to spatial information, GIS or remote sensing in big data? I heard you talked about nearest field. I forget the exact term, but I think you were mentioning something about the spatial relationship data. Do you want to expand upon that a little bit more?
Thank you very much. So, like I said, big data, it's a collection of data from different sources, and the question is asked, and it can be geospatial. And one important thing that we know is that today, even with the COVID and everything, geospatial data has become very useful. So, and for Bdap, for the Bdap program, we are actually, we are not limited to what analysis can be conducted, but we are also going to support project-based learning. And I think Allycia talked about that in our program strategies. So we would be working with existing projects that probably our learners have, or we would also develop projects to that aspect. And then talking about visualization layer also, you see, we can see that the visualization layer will be using resources such as Power BI or Tableau, and these applications use a lot of geospatial data also. So we are hoping that big data covers all of that. It all depends on what tools you have available and what data or what public health problem you want to solve. I don't know if that answers that question.
I think so. It's such a big topic, right? And there's so many places to go with it that it's difficult to put it into one concise sentence or one concise phrase. I'm going to send out a link to folks that CDC did stand up their new center. I was looking at it. It's called the Center for Forecasting and Outbreak Analytics, that will talk about disease modeling and those other components. And I think that published in August of 2021, it sort of got lost in the news cycle and all those things. But for CDC to stand up an entire center based upon it, on activities, is pretty impressive. And I think you'll see a lot more coming out from the agency on that level. The other examples of our centers are focused on environmental health or injury prevention and control or chronic disease. And so to establish its own center is a very bold move for the agency. That hopefully will answer some of the questions about, is there more to find, more ways we can find out about big data analytics programs and those things. And I think we're right at the starting point of a lot of the growth of the training in these areas as well. And then other questions you want to ask, answer in there live, or I have one or two more as well.
I think Allycia is also doing very well with responding to some general questions. I'm trying to, there's a question on if there's a newsletter, there are questions about how can we participate. Okay, the last one, do the presenters have any thoughts about how we could apply a big data perspective in communication, especially for emergency response?
Yeah, what do you think about that?
Yeah, something to think about. I mean, it's all about the data and, available data, and then of course the infrastructure, to process the data, especially real-time for real-time decisions. I mean, that's when it's most valuable, because there's no value in having data that is late. I mean, like packing up your clothes to travel based on weather informations for last week wouldn't help you. So, so I think it's all about the data and then the speed and the processors available. So, but this is, I think this is a good way for us to start, and on unearthing what is available for us even within the CDC, and then how we can close the gaps in terms of capacity as we develop this curriculum together. So for those who are asking questions about the course, we would provide more information when the course, first introduction course is ready, and then we will let you know regarding participation.
Raul, did you want to add to that about communications and big data?
Well, I know that for emergency response, I agree with Juliet that it all depends on the data that we have available, and all these projects are very dependent on that. Now, in terms of communication, I don't have a clear answer. I know, for example, that for emergency responses, there are many cases of communicable diseases in which artificial intelligence and big data and analytics have been used. We have presented several cases here in the slides, and we have the documentation there ready for anybody that would like to take a look at that. Because as I said before, we curated the articles, we did meta-analysis and reviewed a big part of the large part of this of the literature, of the current literature that we've been able to identify. But I don't have a clear answer for, in terms of communication, how that can be applied, big data analytics and machine learning.
I also think a bit about misinformation campaigns and how big data analytics can try to help get in front of those kind of things. I would imagine a lot of the big social media companies are well versed in big data analytics, given the volume that you presented earlier of gigabytes of data every minute going through the internet. So I'd be interested to see. It would be interesting to see. I think it's such a rich field, and I think that's what intrigues me the most. Is how do you get, in particular for public health, how do you stay on top of getting people the right information at the right time? We've always had a wealth of information at the agency and other components of public health, but interpretation of that findings can be really difficult. And I think we as an agency, as CDC, are really working all the time ever since we were created to try to help people understand what that means, what the outcomes of the analyses mean. And I think that pertains still to big data and analytics and those components. You could certainly get, from a physician perspective, say you get real-time blood glucose monitors of real-time what your blood glucose level is. So it really expands exponentially, really, in what you're doing to manage that patient, and then your accountability as a care provider. So if you come and have, not only are you getting real-time blood glucose measurements, but then as a provider, are you responsible for that, monitoring that stream? Are there thresholds that you want to use for cutoffs? And I think that's where public health can be helpful. And then healthcare analytic systems as well. I think with the growth of workforce capacity, particularly in the healthcare field, and particularly in the area of statistical analysis in healthcare field, that was exacerbated or grew out of the Affordable Care Act, with accountable care organizations needing to find patients and ways to address their conditions. It's going to be really important for those healthcare systems to understand the data they have and how they interpret it. And I think you're going to increasingly see a need for analysts and people who have a strong grasp of big data analytics and big data management within healthcare systems, if it's not there already. The other thing that I wanted to touch on is just the cost it takes to even access some of that data, and with some of the large data sets we have, big data sets we have here, there's a significant cost in which to access them, and I think that might exacerbate some inequities that we see in the workforce, or the capacity to analyze that data at the state or local level. A number of states have very strong analytic components and funding, but some states don't. So being able to even have a seat at that table, and not only have a seat, but understand what data I need, because you can't, it's like dipping a cup into a river. You need to really think about where you're going to take your sample from for big data. You can't just throw an entire data set at somebody, or you can't throw your SAS code at some data set and expect it to function anymore. And I'd offer you to expand a little bit upon that, if some of the eye-opening things that you've seen in the last couple of years. And you mentioned some of them, but this growth in analytic capacity, or your own personal growth really in analytic capacity over these years, and what that means for the future.
Okay, you want me to respond to that?
Yeah, give it a run.
Thank you very much. Okay, so talking about data and availability. So for this project, I will narrow down to this project. We are paying more attention to CDC data within the CDC data lakes that are available right now for anyone who have access to utilize. However, we do know that there are other data sources outside of the CDC, and some are free. We have internally also been able to, identify some that are free, like some from Google. But again, it's also important when you start to put the data together to look at also the available infrastructure and web services that you have for this analysis. But this is a starting point for us, and we are starting with data that is available and free, and then moving to data that is not available and all of that. So within this the Bdap program, we are staying with CDC data. We're working. We plan to work with CDC Data Hub to have access to CDC data lakes. And we are also looking at other social media kind of data from Twitter and all of that are available, that we can actually use for our courses, during our courses, as like test data for our courses. However, we have not actually thought about the costs of other data sets that are available out there. And so those are just kind of limitations that we have not thought about for now.
Raul, what do you think about that?
Yes, well, like Juliet has mentioned, we have identified several data sources, some of them within CDC, some others from outside. And the ones that are from outside, obviously, we've tried to focus only on publicly available data. So, and this data, particular, for example, there was a data source that we find very interesting is Opportunity Insights from a researcher at Harvard University, which they did a great job at identifying the data, different data sources, putting them together. So we are currently working on that as well, taking that into consideration for our projects, because the idea here is first, before we get into real or live projects, we want to use a toy data sets from those sources so that we can apply. The idea is to start to learn to walk before we start running. So this is what we are currently doing. So in order to do that, we have to identify the easiest accessible data sets and start playing with them and working on projects. So that we have that in the top of our mind. Yeah.
Certainly. And there's a question about analytic capacity, and certainly in the last year, I've had a chance to look at some of these big data sets, and it's not only just the access to it, but the analytic capacity to do so. And we talk about serial computing or cloud-based computing services where you're able to amplify your ability to analyze or manage large data. I had team members that I helped supervise who would take 8 hours to download a terabyte or so data set. And if you're able to put that into a platform, whether that's chunking the data in some way, you can decrease that to a very short time period. But again, I think we're really well resourced at the agency comparative to some other places. And I have great concerns that we could do more. So I'm very much glad that you are all working on this project. And you can see there's considerable interest in the question and answer box for your information. If you do provide some feedback and you want to connect with folks, we would love to do that. Any closing thoughts?
Exactly, Tony. Just to follow up on your reflection, I think one of the main challenges that we have, everybody has here now, is that there is a deep learning curve. And probably this is where this program comes into play, that we're trying to make this learning curve a little bit softer by trying to learn more about how to have access to these platforms, how to manipulate the data. And then at the end of the day, once we have all this data ready for analysis, apply the appropriate techniques to conduct the analysis. But all of that requires a big process, a large process that unfortunately, I think it's not an easy task. I mean, it requires a lot of learning, and initially it's a very steep learning curve. So I think that's probably one of our motivations or missions in this program, to try to make it easier for everybody to access this data and conduct their own analysis.
Thank you. Juliet, what do you think? Want closing thoughts? And Allycia after that?
Yeah, I agree with you that cloud computing, would be very useful for big data analytics, and within the CDC, we also exploring through the data hub, finding out what cloud computing services are available within the CDC that can support running this large volume of data analysis that we're talking about, without having to run it on our personal computers and have our personal computers crashing up on us at one point or the other. So we are open to collaborations. Actually, we're exploring what is available within our space and working with several communities of practice. There are several communities of practice, machine learning, data science, that we are also collaborating with to see that we're able to provide the right tools for the analysis. And we would also have mentor sessions where people are supported to work in these new environments.
Thank you. Allycia, what do you think?
I really appreciate this conversation. As Juliet was saying, I think, this program is important for not only developing big data analytics application ability and capacity, but also we've had this conversation about making sure that we're incorporating diversity, equity, and inclusion, making sure that we're thinking about being able to analyze quick enough to then use it within communication channels. So again, with this program, we want to create this interdisciplinary environment with just the way that public health was designed. We want to make sure that we are bringing in different parties within CDC to make sure that it's representative and that it's an effective program. So Again, I just really appreciate this conversation, and we're excited to move forward with this program.
We're excited you all had time to present here and very much excited to see your progress in doing so. So thank you all for taking time to come today. Our next Grand Rounds for our audience will be we skip a week forward in January, so it'll be January 12th. We don't hammer you at the Grand Rounds the first week of January, but and we look forward to seeing you there. I don't know if we settled on the exact topic title, so I'm not going to release it, but thank you all for taking time today. We can stop the recording, and thank you to Lillian and Lawrence for setting this up as well.
Thank you for having us.
Thank you very much.
Thank you very much.
Thank you. All take care and stay strong.
You as well. Happy holidays.
Happy holidays.
Thank you. Bye-bye.